Good morning all, I'm Dr. SHEETHAL K B. Today we'll be tackling section 2 of Reading Club based on Misch Implant Dentistry conducted in connection with International Implant Summit 2026. Let's get started with chapter 6, Clinical Biomechanics in Implant Dentistry. Forces. Forces may be described by magnitude, duration, direction, type and magnification factors. Forces acting on dental implants are referred to as vector quantities. That is, they possess magnitude and direction. Restated to state simply that a force of 75 pounds exists on distal abutment is not sufficient. The more correct statement is a force of 75 pounds exists on distal abutment directed axially along the long axis of the implant body. Cantilever length. Large moments may develop from the vertical axis force components in prosthetic environments designed with cantilever extensions or offset loads from rigidly fixed implants. A lingual force component also may induce a twisting moment about the implant neck axis if applied through a cantilever length, as shown in figure 6.8d. An implant with a cantilevered mesobar extending 1 to 3 cm has a significant range of moment loads. A 100 Newton force applied directly over the implant does not induce a moment load or torque because no rotational forces are applied through an offset distance. This same 100 Newton force applied 1 cm from the implant results in a 100 Newton centimeter moment load. Similarly, if the load is applied 2 cm from the implant, then a 200 Newton centimeter torque is applied to the implant bone region. And at 3 cm, a 300 Newton centimeter moment load results. For comparison, recall that implant abutments typically are tightened with 30 Newton centimeter of torque. Moving on to occlusal width, wide occlusal tables increase the moment arm for any offset occlusal loads. Facial-lingual tipping rotation can be reduced significantly by narrowing the occlusal tables or adjusting the occlusion to provide more centric contacts. In summary, a vicious, destructive cycle can develop with moment loads and result in crestal bone loss. As crestal bone loss develops, occlusal height automatically increases. With an increased occlusal height moment arm, the facial-lingual microrotation and rocking increases and causes even more crestal bone loss. Unless the bone increases in density and strength, the cycle continues to spiral towards implant failure if the biomechanical environment is not corrected. Fatigue failure. Fatigue failure is characterized by dynamic, cyclic loading conditions. 4 fatigue factors significantly influence the likelihood of fatigue failure in implant dentistry. 1. Biomaterial, 2. Macrogeometry, 3. Force magnitude, and 4. Number of cycles. Fatigue behavior of biomaterial is characterized graphically in what is referred to as an ascent curve, a plot of applied stress versus number of loading cycles as shown in figure 6.10a. If an implant is subjected to an extremely high stress, then only a few cycles of loading can be tolerated before fracture occurs. Alternatively, an infinite number of loading cycles can be maintained at low stress levels. The stress level below which an implant biomaterial can be loaded indefinitely is referred to as its endurance limit. Titanium alloy exhibit a higher endurance limit compared with commercially pure titanium as shown in figure 6.10b. The geometry of an implant influences the degree to which it can resist bending and torsional loads and ultimately fatigue fracture. Implants rarely, if ever, display fatigue fracture under axial compressive loads. To the extent that an applied load stress can be reduced, the likelihood of fatigue failure is reduced. As described previously, the magnitude of loads on dental implants can be reduced by careful consideration of arch position, that is, higher loads in posterior compared with anterior mandible and maxilla. Elimination of moment loads and increase in surface area available to resist an applied load, that is, optimize geometry for functional area or increase the number of implants used. Finally, fatigue failure is reduced to the extent that the number of loading cycles is reduced. Thus, aggressive strategies to eliminate parafunctional habits and reduce occlusal contact serves to protect against fatigue failure. Heading on to chapter number 7, Stress Treatment Theorem for Implant Dentistry. Biomechanical overload, under which we have surgical failure. There are many reasons for the failure of an implant to integrate initially with the bone. The primary causes of early failure relate to excessive heat during the preparation of osteotomy or excessive pressure at the implant bone interface at the time of implant insertion as shown in figure 7.2. The excessive pressure, that is pressure necrosis at implant insertion, is observed most often in more dense bone. Example D1 or D2 with a greater thickness of cortical bone. An additional cause of surgical failure is micro-movement of the implant while the developing interface is established as shown in figure 7.3. A fractured arm is immobilized to prevent movement at the fracture site to decrease the risk of a fibrous non-union. Movement as little as 20 micron has been reported to cause fibrous interface to form at the fracture site. Brensky observed a fibrous tissue interface development when a dental implant moved more than 100 micron during initial healing. Early loading failure. On occasion, an implant may fail shortly after it has initially integrated to the bone. Before failure, the implant appears to have rigid fixation and all clinical indicators are within normal limits. However, once the implant is loaded, the implant becomes mobile shortly thereafter. This has been termed early loading failure by Jivedin and Misch. The cause of early loading failure is usually excessive stress for the bone implant interface, which has been documented in many studies. Early implant failure from biomechanical overload as high as 40% has been documented in the softest bone types. No reports in the literature correlate such high incidence extreme with early implant failure rates related to the biological width related complication observed in the field. Impact of occlusal overload on mechanical components, under which we have screw loosening. Abutment screw loosening has been shown to be the most common dental implant prosthetic complication, accounting for up to 33% of all post-implant prosthodontic issue. The incidence of screw loosening with single implant crowns has been reported as high as 59.6% within 15 years of placement. Unfortunately, screw loosening may cause many complications that contribute to crestal bone loss, screw fracture, implant fracture, or implant failure. Although screw loosening may occur in any area of the oral cavity, studies have shown the overwhelming majority of loosened screw occur in the maxillary and mandibular molar areas, approximately 63%, and with single implant crown restoration, approximately 75%. Periosteal reflection hypothesis. Periosteal reflection causes a transitional change in the blood supply to the crestal cortical bone. 90% of the arterial blood supply and 100% of the venous return are associated with the periosteum in the long bones of the body. When the periosteum is reflected off the crestal bone, the cortical bone blood supply is affected dramatically, causing osteoblast death on the surface from trauma and lack of nutrition. These events have fostered periosteal reflection theory as a cause for early bone loss around an endosteal implant. Although crestal bone cells may die of initial trauma of periosteal reflection, the blood supply is re-established once a periosteum regenerates. Biologic width hypothesis. The sulcular region around an implant and around a tooth are similar in many respects. The retipec formation within the attached gingiva and the histologic lining of the gingiva within the sulcus are similar in implants and teeth. A free gingival margin forms around an implant with non-keratinized sulcular epithelium, and the epithelial cells at its base are similar to functional epithelial cells described with natural teeth. However, a fundamental difference characterizes the base of the gingival sulcus. For natural tooth, an average biologic width of 2.04 mm exists between the depth of the sulcus and the crust of the alveolar bone, as shown in figure 7.13. It should be noted the biological width is actually a height dimension with a greater range in the posterior region compared with the anterior region, and may be greater than 4 mm in height. In teeth, it is composed of connective tissue attachment,
1.07 mm average above the bone and a junctional epithelial attachment 0.97 mm average at the sulcus base, and the most consistent value between the individuals is the connective tissue attachment.
11 different gingival fiber groups are observed around a natural tooth: dentogingival, coronal, horizontal and apical, alveolo-gingival, intercapillary, transgingival, circular, semicircular, dentoperiosteal, transseptal, periosteogingival, intercircular and intergingival. At least 6 of these gingival fiber groups insert into the cementum of the natural tooth. The dentogingival, coronal, horizontal and apical, dentoperiosteal, transseptal, circular, semicircular and transgingival fibers. In addition, some crestal fibers from the periodontal fiber bundles also insert into the cementum above the alveolar bone. However, in a typical implant gingival region, only 2 of these gingival fiber groups and no periodontal fibers are present, as shown in figure 7.15. These fibers do not insert into the implant body below the abutment margin as they do into the cementum of natural teeth. Instead, the collagen fibers in the connective tissue attachment around an implant run parallel to the implant surface, not perpendicular such as with natural teeth. The gingival and periosteal fiber groups are responsible for the connective tissue attachment component of the biologic width around teeth, and these are not present around the transosteal region of an implant. Therefore, connective tissue attachment around the abutment implant connection cannot be compared with the connective tissue attachment of a tooth. It is unable, however, to constitute a junctional epithelial attachment component of the biologic width similar to the one found with natural teeth. The amount of early crestal bone loss therefore seems unlikely to be solely the result of the remodeling of hard and soft tissues to establish a biologic width below an abutment connection. The crevice between the implant and the abutment connection has been called a micro gap. The actual dimension of this connection is usually 0 mm and has a direct metal-to-metal connection. However, when the crevice is exposed to the oral environment, bone loss is usually observed for at least 0.5 mm below the connection. It is true that bone loss does occur around an exposed abutment implant connection placed below the bone and is observed within 2 to 4 weeks once a connection is exposed to the oral cavity. The bone loss often occurs before the implant is loaded with the processes. It is logical to call this marginal bone loss the biological width. Moving on to implant design biomechanics. Implant design may affect the magnitude or type of forces applied to the bone-implant interface. A smooth collar at the crest module may transmit shear forces to the bone. Bone is strongest under compressive forces, 30% weaker under tensile loads and 65% weaker to shear forces. Moving on to bone density, the density of the bone is directly related to the strength of the bone. Misch and colleagues have reported on the biomechanical properties of 4 different densities of the bone in the jaws. Dense cortical bone is 10 times stronger than the soft, fine trabecular bone. D2 bone is approximately 50% stronger than D3 bone. In addition, the stiffness of the bone is affected by the bone density. Young's modulus for compact bone is 10 times larger than that for cancellous bone. The denser the bone, the stiffer the bone, and there is less biomechanical mismatch to titanium during loading. Now we have key implant positions and implant or abutment number, under which we have key implant position. If a terminal abutment is not present, a cantilever is created which magnifies the stress to the rest of the support system. Cantilevers are a force magnifier and represent a considerable risk factor in implant support, screw loosening, crestal bone loss, fracture, and any other items negatively affected by force. Therefore, the goal of implant position should be to eliminate cantilevers whenever possible, especially when other force factors are increased. In a 5 to 14 unit processes, intermediary abutments are also important to limit the edentulous spans to less than 3 pontics. A 3 pontic processes flexes 18 times more than a 2 pontic processes, whereas a 2 pontic restoration flexes 8 times more than a 1 pontic process.
The canine is an important implant position whenever the canine and 2 adjacent teeth are missing. Therefore, when the 2 premolars, a first premolar and a lateral, or a lateral
and a central are missing next to a canine implant is warranted. In addition, the ideal occlusion for an implant process is implant-protected occlusion. This entails disoccluding of the canine. Therefore, an implant in this position has significant occlusion benefits. Implant size. An excessive implant length is not critical at the crestal bone interface, but it is critical for initial stability and overall amount of bone implant interface. The increased length also provides resistance to torque or shear forces when the abutments are screwed into place. However, the additional length does little to decrease the stress that occurs at the transosteal region around the implant at the crest of the ridge during occlusion loading. Therefore, the excessive implant length is not as effective in decreasing stress from force factors. Wider root form implants have a greater area of bone contact than narrow implants of similar design, which is a result of their increased circumferential bone contact areas. Each 0.25 mm increase in implant diameter may increase the overall surface area approximately 5 to 10% in a cylinder implant body. Implant design. A cylinder bullet-shaped implant provides 30% less surface area than a conventional threaded implant of same size. Chapter 8. Treatment Planning. Force factors related to patient conditions. Bite force. The greatest natural forces exerted against teeth and thus against implants occur during mastication. These forces are primarily perpendicular to the occlusal plane in the posterior regions, are of short duration, occurs only during brief periods of the day, and range from 5 to 44 pounds for natural teeth. The actual force on each tooth during function has been recorded on strain gauges in inlays. A force of 28 psi was needed to chew a raw carrot and 21 psi was needed to chew meat. The actual time during which chewing forces are applied on the teeth was about 9 minutes each day. More recent studies indicate normal maximum vertical biting forces on teeth or implant can range from 45 to 550 psi. The forces on chewing side and the opposite side appear very similar in amplitude as shown in table 8.1. Abde et al. Evaluated maximum bite force in endodontically treated teeth versus natural vital teeth. They showed the maximum biting force was significantly higher in root canal teeth in comparison with vital natural teeth. The loss of the mechanoreceptor-mediated protective mechanism allows for the increased biting force. Therefore, caution should be exercised when an implant processes or poses an endodontically treated tooth because protective modifications need to be addressed in the occlusion and processes design. Parafunction. The most common cause of both early and late implant failure after successful surgical fixation is a result of parafunction. Such complications occur with greater frequency in the maxilla because of a decrease in bone density and an increase in resulting moment of force. The presence of these conditions must be carefully noted during the early phases of treatment planning. Bruxism. A 37-year-old patient with a long history of bruxism recorded a maximum bite force of more than 990 psi, 4 to 7 times normal. Diagnosis. Bruxism does not necessarily represent a contraindication for implants, but it does dramatically influence treatment planning. The first step is to recognize the condition before the treatment is rendered. The symptoms of this disorder, which may be ascertained by a dental history, may include repeated headaches, a history of fractured teeth or restorations, repeated uncemented restorations, and jaw discomfort upon awakening. Bruxism changes normal masticatory forces by magnitude, higher bite forces, duration, hours rather than minutes, direction, lateral rather than vertical, type, shear rather than compression, and magnification 4 to 7 times normal. Fatigue fractures. A bruxing patient is at greater risk for fatigue fractures for 2 reasons. The magnitude of the forces increases over time as the muscles become stronger and the number of cycles increases on the prosthetic components. Eventually, one of the components, that is implant, screw, abutment, prosthesis, will break if the parafunction cannot be reduced in intensity or duration as shown in figure 8.7. No long-term prosthetic result is expected in patients with severe bruxism.
Therefore, once the implant dentist has identified the sources of additional force on the implant system, the treatment plan is altered in an attempt to minimize the negative effect on the longevity of the implant, bone, and final restoration. All elements able to reduce stress should be considered. Occlusal guards to determine direction of force. No study demonstrates an increase in parafunction after occlusal adjustment. Therefore, the ability to decrease the risk for occlusal overload on particular teeth and the added benefit of perhaps reducing parafunction is warranted in almost every patient diagnosed with a parafunctional habit of bruxism or clenching. The term night guard is often used to describe this type of prosthesis. However, this prosthesis should be termed an occlusal guard, as a night guard may be misconstrued to be used only at night. The occlusal guard can be a useful diagnostic tool to evaluate the influence of occlusal disharmony on nocturnal bruxism. Clenching. Clenching is a habit that generates a constant force exerted from one occlusal surface to the other without any lateral movement. Diagnosis. Many clinical symptoms and signs warn of excessive grinding. However, the signs for clenching are often less obvious. The forces generated during clenching are directed more vertically to the plane of occlusion, at least in the posterior regions of the mouth. Wearing of teeth is usually not evident. Therefore, clenching often escapes notice during the intraoral examination. As a result, the dentist must be more observant to the diagnosis of this disorder. Fatigue fractures. A common cause of implant failure during healing is parafunction in a patient wearing soft tissue supported prosthesis over a submerged implant. The tissue overlying the implant is compressed during the parafunction. The premature loading may cause micro-movement of the implant body in the bone and may compromise osseointegration. When an overlying soft tissue bone restoration exerts pressure as a result of parafunction, pressure necrosis causes soft tissue dehiscence over the implant. Treatment planning for bruxism and clenching, under which we have progressive bone loading. The time intervals between prosthodontic restoration appointments may be increased to provide additional time to produce load-bearing bone around the implants through progressive bone loading techniques. By using the progressive bone loading technique, poorer bone density may be transformed into better quality bone, which is more ideal for adapting to excessive occlusal loads. Treatment planning for tongue thrust and size. Even in the absence of tongue thrust, the tongue often accommodates to the available space, and its size may increase with the loss of teeth. As a result, a patient who is not wearing a mandibular denture often has a larger than normal sized tongue. The placement of implants and prosthetic teeth in such a patient results in an increase in lateral force which may be continuous. The patient then complains of inadequate room for the tongue and may bite it during function. However, this condition is usually short-lived and the patient eventually adapts to the new intraoral condition. However, it has been observed that a fixed restoration is more advantageous for this type of patient. If the patient has an RP5 prosthesis, it should be turned into an RP4. An RP5 restoration is much less stable in patients with tongue thrust or size issues, and the patient complaints are more common with removable restorations in general. Crown height space. The interarch distance is defined as a vertical distance between the maxillary and mandibular dentate or dentate arches under specific conditions. Example, the mandible is at rest or in occlusion. A dimension of only one arch does not have a defined term in prosthetics. Therefore, Misch proposed the term crown height space, CHS. The ideal crown height space needed for a fixed implant prosthesis should range between 8 and 12 mm. Removable prosthesis often requires a crown height space greater than 12 mm for denture teeth and acrylic resin-based strength, attachments, bars, and oral hygiene considerations. For a bar over denture, approximately 15 mm is usually necessary, especially if being restored with acrylic or denture teeth prosthesis. Figure 8.34. The maximum bite forces are greater in the posterior regions of the jaw compared with the anterior regions, approximately 5:1. Chapter 9. Dental Implant Surfaces. Introduction.
Successful oral rehabilitation with dental implants is dependent on the interrelationship of the following key determinants of lifelong osseointegration presented by Albertson and colleagues. 1. The status of the implant bed. The patient must exhibit a state of general health that will support the healing process. In addition, bone of sufficient quality and quantity is required. 2. The surgical technique. Successful treatment requires the use of proven surgical principles as well as instruments, equipment, and techniques appropriate for the specific implant systems. 3. Long-term loading. After successful implant placement, protocols for processes design, selection of restorative materials, occlusal relationships, aesthetics, and maintenance must be followed to support the long-term health of the implants. 4. Biocompatibility of implant material. Dental implants must be constructed of materials that will be tolerated by patient and not generate significant antigenic responses. Although commercially pure titanium and titanium alloys predominate, there are other materials, most notably zirconia, that are also used. Implant macrostructure or overall design of the implant. Although many different implant designs have been studied and used, the most widely used designs have converged to favor a taper screw shape with an internal connection. 6. Implant microstructure or surface. Surface of an implant and the response elicited from the patient's soft and hard tissue is the topic of this chapter. The surface structure of dental implants has proven to be critical for adhesion and differentiation of cells during the bone remodeling process essential to osseointegration. Surface roughness. The process of osseointegration begins with the interaction of cells in the immediate area with the implant surface. The surface roughness of dental implants has a significant effect on the process of osseointegration. It is crucial in the formation of bone because although fibroblasts and epithelial cells adhere more strongly to smooth surfaces, rough surfaces enhances the adhesion and differentiation of osteoblastic cells, allowing for the deposition of bone. Review of implant surfaces. After the machining of a commercially pure titanium or titanium alloy implants, contact with air causes the immediate development of titanium oxide surface on the implant. Subtractive processes. Etching with acid. Acid treatment of a titanium implant removes the surface oxide and any contamination, resulting in a clean, homogeneous surface. The acids used include hydrochloric acid, sulfuric acid, hydrofluoric acid, and nitric acid. Acid etching of titanium and titanium alloy implants result in uniform roughness with micropits ranging in size from 0.5 to 2 micrometer and an increase in surface area. Acid treatments of implant surfaces enhances osseointegration through improved migration and retention of osteogenic cells at the implant surface. Blasting with an abrasive material. Blasting the implant surface with hard ceramic particles projected through a nozzle at high velocity is another method of surface roughening. Different surface roughness can be achieved based on the size of the blasting media particles. Several materials have been used, including alumina, titanium oxide, and hydroxyapatite. Implants with a resorbable blast media surface treatment in which hydroxyapatite is used as the blast media offer particular advantages because, unlike blasting with aluminum oxide, grit, or sand, any particles remaining on the surface are resorbable and do not affect healing in the immediate vicinity because of the presence of foreign particles. Hydroxyapatite is also a component of bone. Thus, blasting with hydroxyapatite is not only biocompatible and resorbable but also osteoinductive. Additive processes. Additive processes share the same goal, which is to roughen the implant surface to accelerate osseointegration, particularly in lower bone densities. Hydroxyapatite coating and titanium plasma spraying. Overall, there are major concerns with the use of plasma sprayed coatings. In the case of both hydroxyapatite and titanium plasma spray-coated implants, the surface roughness is at a higher level than the moderately rough that is currently considered optimal. Such rough surfaces are also thought to contribute to the spread of peri-implantitis when the surface is exposed to oral cavity and facilitates the formation and retention of plaque. As with the hydroxyapatite coatings, delamination of the titanium particles in titanium plasma spray implants has been observed, leading to mobility and eventually loss of implants. Oxidation or anodization. After such treatment, the surface oxide increases from an approximately 5 nanometer thickness to 3 micrometer or more. A positive correlation was found between increasing height deviation of the treated surface and implant healing when oxidized implants prepared at different voltages were compared.
This means that implants with a thicker oxidation layer had greater bone implant contact compared with those with a thinner oxide layer. However, an oxide layer greater than 3 micrometer in thickness did not cause any further increase in bone implant contact.
Biological responses and interaction with implant surface. Osseointegration of a dental implant after placement into prepared osteotomy follows 3 stages of repair. 1. Initial formation of a blood clot, 2. Cellular activation, and 3. Cellular response. After implant placement, the blood components interact with dental implant surfaces, leading to the adsorption of plasma proteins such as fibrin on the implant surface. The migration of bone cells necessary for osseointegration then occurs through the fibrin clot. The ability of an implant surface design to retain fibrin during the wound contraction phase of healing is critical in determining whether the migrating cells will reach the implant. Bone cells reach the implant surface by migration through fibrin and other early structural matrix proteins and lay down bone on the implant surface itself.
Moderately rough and rough surfaces promote this activity by providing surface features with which fibrin can become entangled and by increasing the available surface area for fibrin attachment. Bone cell migration and bone formation observed on titanium implant surface are also thought to be related to the similarity between the micro-roughness of the surface and the pitch irregularities found in natural bone surfaces resulting from osteoclast activity. After implant placement, remodeling of the surrounding bone occurs by osteoclastic activity, which removes some of the existing bone around the implant. The natural surface of demineralized bone matrix created by osteoclast resorption process is rough and pitted. This becomes the recipient surface for new bone formation. Under future directions, we have bisphosphonate surfaces. Bisphosphonates are anti-resorptive agents known to inhibit osteoclast activity that are used in the treatment of osteoporosis. Bisphosphonate-loaded implant surfaces have been reported to improve implant osseointegration. It has been shown that bisphosphonate incorporated onto titanium implants increased bone density locally in the peri-implant region with the effect of anti-resorptive drug limited to the density of the implant. Statins. Statins are commonly prescribed drugs that decrease cholesterol synthesis by the liver. This reduces serum cholesterol concentrations and lowers the risk of heart attack. Simvastatin induces the expression of bone morphogenic protein 2, BMP2 mRNA that promotes bone formation. Ayukawa and colleagues confirmed that topical application of statin to alveolar bone increased bone formation and concurrently suppressed osteoclast activity at the bone healing site. In addition, clinical studies reported that statin use is associated with increased bone mineral density. Antibiotic coating. Antibacterial coatings on the surface of the implants that provide antibacterial activity to the implants themselves have been studied as a possible way to prevent surgical site infections associated with implants. Zirconia implants. Zirconia implants are often one-piece implants, which means that both the implant body and the permucosal portion can be digitally designed to fit the local anatomic conditions and individually machined. One-piece implants have the advantage of no implant abutment movement. Zirconia implants perform well in areas with thin soft tissue biotype and in cases in which soft tissue recession might expose some part of the implant. With this, we have arrived at the conclusion of session 2. Thank you for listening.